if you heard about the mini implants, they were started with Imtech brand, and then it was transferred to 3M, and they stopped it actually a few years back, and there are other versions of it in different companies, Implantium and so on. The narrow diameter implants, it was initially used as a transitional type of implant for while you're doing your standard implant placement and you're waiting for healing and you're trying to provisionalize the patient and give them something temporary. They were used for that, but then they find out that they work pretty well, and they're so integrated with the bone, and there is no need to be removed and go through all of that. So Victor Sendex changed the plan, and since 1998, I think he started, and then 99, he introduced this new system, and then later on they got the FDA, and it was quite wild for a while, maybe 2005, 2006. It was very wild and used everywhere, especially for the lower mandibular denture to stabilize them and turn them to an overdenture. And it was an easy system. It was a simple system, and you could offer your patients that were suffering from mobile dentures to have an overdenture in probably about an hour without a major surgery, and that was quite a revolutionary change. But then they come up with more problems, and they stopped it actually. I think financially it wasn't viable for 3M, and they stopped it. Because of the limitation of the time frame that they were used, there wasn't much of data. There is, even if you look at the literature, you can't really find much of data of how they perform and how they can be compared to conventional implants in terms of success and osseointegration. So these guys started comparing them in terms of bone implant contact and comparing them with teeth and standard implants. And in a small, comparison, they found out the surface area of the mini implants are much, much less compared to natural teeth or implants. They almost less than half. And in that view, it should not work, but they work. So they came up with the idea that it might be safer to join them together. If they are used in a joint prosthesis, they work much better. But like I said, there's not really any concrete literature and data about how they perform. There was a study, a nice one actually, done on rabbits, about 9 rabbits. They started to put implants in tibia. They compared the mini implants, which is 1.8 by 10 millimeter, the narrowest one they could have, to ankylosed implant 3.5 by 8 millimeter, and used about 18 of each implants in non-rabbits, and compare. What they did is they infused resin into the specimen and then washed, and after 6 weeks watched how much of bone osseointegration is happening in both of them. So the interesting data was actually the osseointegration in both of them are quite similar. So despite their narrow diameter, they perform well in terms of osseointegration. So the question is, when we feel confident, restoring a full arch on 6 of ankylosed implants or even less, why shouldn't we feel comfortable about using miniature implants instead of those, or mini implants? But the question is why we so much push for mini implants and compared to standard implants while we have the standard implants and all of the data behind it. Well, the answer is quite simple, because most of the time they can be placed without drilling into the bone. We know all of the problems come from large procedures and drilling into the bone that can end up with many complications. So they are much easier to place in the bone. Most of the time you don't need drilling in the bone. They're very minimally invasive, and the good thing about them is they are self-advancing, self-drilling, so you can insert them just using your fingers and torque wrench, and you're done. In narrow bone, because they can kind of expand the bone, they can be placed in very narrow bone, while you can't do it with standard implants. You have to augment the bone. Morbidity is much less, because you don't raise a major flap, you don't drill, medically compromised patients that have all sorts of problems and stop you from raising a flap and causing bleeding and so on. And also, if you don't drill in the bone, you're probably less likely to end up in anatomic areas and cause more risk to the patients. Faster recovery because you don't raise a major flap, and cost effectiveness, actually, that's more desirable for patients. So going back to the reasons, I mean, we all learned about all magnificent techniques and great ways of augmenting the bone, but none of us can tell, if we perform the augmentation on a patient on Monday, we're not going to end up with this situation, no matter how good your skills are, no matter how good the patient is, and that can become a disaster for, ruin your career for 1 year at least. It can be manageable if you have a good patient, but, how many good patients we see every day? so that can probably, be your nightmare if you go through all of those augmentation and procedures and so on. So going back to the interest in mini implants, my master thesis was about the success rate. It's just a comparison of the systematic comparison of the success rate of mini implants. And looking into literature, all I found was all of those studies, the success rate is not really low. It's starts minimum from 92% up to very high rate. That is about the same range that you have with conventional implants. So in terms of success rate, there's not really much of change. There's not much of difference in between the two. However, this is based more on the data that are taken from overdenture, the protocol for overdenture, and that goes mainly towards implant implants at the time. And the literature is very poor in terms of using mini implants for fixed restorations. You can't really find much of data about it, and very limited articles you can see. They are not even peer-reviewed, but they just presented how mini implants are used for fixed restorations, and in that case, it's used for 2 crowns, trying to be a guided surgery procedure without raising a flap. So that's all you can find in terms of fixed restorations. But in terms of now that we're pushing towards mini implants, what's the complication? What's the risk of using them? And the main risk that you probably face, apart from the common complication that you have with any implant placement, comes back to fracture. One of the pushbacks for implant was they fracture quite easy. And there's quite a large basically concept about why they fracture. Comes back to the protocol of their use, where they used, and the material of that, and also the design of the implants. So that was the main problem. If you ever have experience with using those implants, they tend to fracture quite easily during the placement. And also comes back to restorative complications, because they're not designed in any form. They're not designed for fixed restorations. So dentists, I've seen many dentists trying to be innovative and trying to restore it in different ways, build up around with composite, or deal with it like a normal crown and tooth crown. But there's no control on it, and there's no clean-cut protocol about it, and they can end up with many problems. And that's why we see pre-implantitis become a common problem with those in long term, and also comes back to survival of those implants. In terms of how we can prevent fracturing those implants, this one study done actually prior to implant implant, but it was done in laboratory about the whole concept of mini implant, about orthodontic implants basically. And what they did, they cut about 450 implants in their own lab, started from 1.2 with increment of 0.1 increase in diameter. So the largest one was the thickest one was 2 millimeter mini implant. And they tried to insert it into resin and also bone. But what they aimed for, it was the high density bone and high density resin compared to density 1 bone. And what they find out is there is direct correlation between the increase in diameter and resistance to fracture. So the safest one was at implant with 2 millimeter diameter that could prevent fracturing at 40 or 35 Newton. And having said that, host of the implant placement plays a big role, because if you're trying to put it in a D1 bone with high cortical amount of bone in there, you have more resistance, and that's what that study was about. So if you try to use mini implants in D1 bone and you have a 2 millimeter diameter up to 35 Newton, you're safe. So you don't have much of risk of fracturing the implants. But then another problem is, like I said, if they are used for fixed restorations, how you can do it? What's the best way of doing it? This is a nice case actually that was done by a colleague, and they are Aiden implants. Implants are done pretty well. Restorative, if I'm not wrong, I think 2 years later, patient comes back with pre-implantitis in major problems and ended up taking out everything. And there you go, that's the picture. But you can quite clearly see the retentive form of the bridge, and also all sort of excess cement is hanging around, and that's causing the pre-implantitis and failing of the whole system. So like I said, they're not designed for fixed restoration, and if you try to be smart and get around it, that may be something that you face in future. Another problem is the design and the form of it, because they are simply designed for a simple placement in the mandibular jaw for overdenture. The design, if you're using it for fixed restoration, can be very tricky to get around, because then you have part of the implant sometimes exposed, and that can be potential source of pre-implantitis and problem down the track. So what happens is, back in 2015, I started developing this type of implant, and at the beginning, whoever I discussed it with said, it's a rubbish idea, don't waste your time. And Professor Netwig was one of the lecturers here, and the teachers here, and he said, it's a wonderful idea. Is he? Okay, I think he sent me an email, said he's retiring or partially retiring or something. Oh, right, okay. Now, he said it's a good idea, go follow it. That's the way to go. And I said, if the whole world say no, and he says yes, he's the expert, I'm going to follow it. So, and that's the initial concept, but then as we started using it and practical concepts and experience come to it, we changed this to the final design that you see here. It's one piece, simple mini implant. It's designed to be self-advancing, self-drilling, and that's why it's got a bit of aggressive thread in there. The top part, I tried many other ways, but that's probably the best way to plan for future problems. If you have pre-implantitis, what you're going to do? What's the first step you want to do? The first step is just trying to sand around the implant and get a smooth finish. And that 1 millimeter safeguard gives you that. But if you leave it long, then obviously you end up with more problems, and it will be more difficult to get around it. They have hex. So the top head of the implant is like a multi-unit abutment that you can see. Almost all systems have it. And also it becomes like a tissue level implant. So in another way is taking all sort of good concepts that we learned from different implants in years, trying to put it in one package. It comes with a socket that is connected to it, so it allows you self-drilling or self-placement. Comes with a finger wrench that is connected to it in the lid of the vial, so you can take it out with your finger, place it in the bone, and when you feel resistant, then you can start using your machine or hand wrench or whatever you want to do. And the top part, you can use it because it's sandblast. It can be used as a scanning gauge for you. It can be used as a pickup abutment. It can be used as an impression coping, and many other ways that you can, or temporizing or whatever. So that's the first case we used those implants for her back in 2018, end of 2018. periodontitis, advanced periodontitis, severe mobility under 4 and 2 and 2.2 and 2.4, and pocketing and all sorts of problems, and very thin bone, as you can see from the ridge. So, raising a flap, you can see the best you can predict for that is about 3 millimeter diameter in terms of the bone. What you can do for placing an implant, the only way it would be augmented, split, ridge, or whatever technique you want to use. But like I said, that's all come with complication, and who wants a complicated system while you have a simple way? So it's just a bone marking, using a bone mark about 3 millimeter or 4 millimeter into the cortical bone so your implant doesn't slip. And you pick it up, place it in, 6 implants, done, and that comes back 10 weeks later for impression or scanning or whichever technique you want to do, and end up with a prosthesis. There's a hybrid PMMA with a titanium bar inside it. That is almost 4 years that she lives with that, and that's 3 years follow-up result. So the fact that you don't have a micro gap between the abutment and implant, is kind of like a tissue surface implant, gives you a stability. You can imagine in that narrow bone which implant you can slide in. This is just self-driven into the bone and directs itself right into the cancellous bone because it faces less resistance, and no guided surgery whatsoever is done. But 3 years later, I had the luxury of buying a CBCT machine and take it, and I was surprised, how beautiful it is slipped into between the cortical bones. Then once you get confidence of you have to use them, then you start using them for almost for every case. Severe terminal dentition, complete failure of the dentition. All the teeth are taken out, cleaned up, and at the same time implants are placed in. 10 weeks later, see the patient with a bit of overgrowth of the soft tissue over one of the implants. The rest are pretty healed up, and the prostheses are made, put in, fixed, and 2 years follow-up due to COVID, and didn't see the patient. He's kind of disappeared, and 2 years later he comes and now take an OPG, and the bone is pretty stable. So with that dramatic pre-implantitis situation and all of that risk, this is what we end up seeing. And the interesting thing is you can see the cantilever part of the bridge is still well extended on each side of it, and no fractures, nothing happened. Then whether you can only use it for thin bone? No, really. You can use it for any, once you have that ability to use it for thin bones, then you can use it for, large volume of bone. That's a simple placement, punch into the tissues, and implants are done, and that's the images at the healing stage. And that's the X-ray that is right after implant placement. What I was going to mention is, probably it will be a question for you, whether they can be only parallel to each other, or they can be convergent or divergent or whatsoever. No, you can, like the luxury of multi-units, you have that ability to make it angle towards each other, and you have the ability to go up to 40 degrees against each implant. So the restoration comes back whether you use a milled prosthesis or milled bar, or you're using a pick-up or wrap-up type of prosthesis. That can be dealt with at that stage. So that's right after placement, and this is after finishing the prosthesis and fitting it in. And the interesting thing is that's the prosthesis done top and bottom, fixed restoration, PMMA on the titanium bar, and that's 6 months follow-up. So you can still see the sides of the extraction sides are still healing, and the implants are there, but then 2 years follow-up, bone level is pretty much stable without the change. Okay. I haven't done, basically the focus was to see whether they work and what's the survival and success of those. I haven't done any study on the bone loss or marginal bone loss, but from the follow-up of all of that, what I faced is all the time is bone level and marginal bone level is pretty stable. And the fact is just thanks to the fact that they are tissue level surface, they have no micro leakage, no micro pumping between the components, and work absolutely fine. Whether you can use them by their own or they can be combined with implant. I mean, how many of us, we see situations that you have one in some spots and you don't have one in the rest of the jaw. So you can combine them with any other implant, especially when you do a full arch restoration. This is a case that I was planning to do ankylosed implants. I placed 3 ankylosed implants. You can see from the balance space, the bottoms are narrower. And then the rest of the bone is so crumbling, so narrow, that every time I was trying to put my drill in, the bone just disappears. This crumbles away and fractures away. So quickly picked up 3 of those miniature implants, placed them in, hand tighten, done. Another case, patient had 5 implants done in Thailand, and comes back a couple of years later with the middle one right in the palate and with pre-implantitis failing. I took that one out. And because of the failure of the conventional implant, you lose a lot of bone. So basically, you don't have a place to do another implant unless you augment it. But we didn't want to do that. So I quickly picked up a miniature implant in the middle of the jaw and placed it without any drilling. And the interesting thing is she came back February this year, and all 4 other implants had pre-implantitis. So I had to treat them all, except the one that I did for her almost goes back 3 years back. So that's the luxury of having those. So another case, an interesting case, that's a patient with those 2 teeth going, and they need to be replaced with implants, and all of a sudden I'll take an OPG and see whether the mini implants are restored. I didn't even see it really. Because it was built up with composite around it, but it's pretty stable, and despite the bone loss around it, it works really fine, and I was surprised. But anyways, I took those 2 teeth out and placed in a couple of BioHorizon implants, the 3 millimeter diameter, trying to restore for her, augmented, put a membrane on, and comes back 10 weeks later, that implant is failed. It's not even integrated. So comes back, and I had to remove that implant, allow it a little bit of time to heal, about 2 months and 10 weeks, and then I take a scan, the bone is really not there. You can't do another implant. And the only way that I could get around and fix up is just to put a mini implant, which is a 2.4 diameter implant, and go ahead and restore it. That's the bridge, done. So simple as that. So it can be joined with other implant systems, and it doesn't limit you, so you don't have to be just one implant system at a time. I just want to show you a few applications how they can be used and where they can be used. That's 2 premolar teeth missing, and he can't afford basically going through standard implant because the mini implants are quite affordable, and just a tissue punch, 2 implants placed in, just with finger torque, and also torquing a little bit deeper using your wrench, and comes back 10 weeks later, take an impression, and that's the final restoration done without going through any surgical procedures for. How stable they are, and that's an interesting case. This is an 84-year-old man that initially wanted an overdenture and then changed his mind and wanted to go towards a fixed restoration. And what I did, I placed the mini implants, the miniature implants, 6 of those, and right away I loaded them. I took impression. Next day, they are already 2 days later, they are already there. So the implants are placed in. That's the provisional that is a PMMA printed PMMA prosthesis made and immediately loaded, and comes back 3 months later, soft tissue healing, and then you go towards the definitive restoration. So despite the narrow diameter, they can be immediately loaded. Very interesting case. Severe atrophy. She had 2 one-piece biohorizon implants. I think they are 3.2 or 3 millimeter in diameter. She had an overdenture, failed one, and another one comes with severe pre-implantitis and massive loss of bone. And the top jaw, the other side, is with impacted tooth 3, and then massive expansion of the sinus. So the only option would be to either go to severe augmentation, go to quite an extensive augmentation and procedures like that. But even for the bottom jaw, that would have been a very risky option, because you not only have to augment the bone, you have to augment the tissue as well. And that's expensive, that's invasive, and patient doesn't want to do that. So what we do is, in one stage, I had to just treat the top jaw, because no matter how good those implants are, they only compensate for the width. They're not compensating for the height. So for that case, I had to do lateral sinus lift. And 4 months later, I decided to go ahead and place the implants. And probably a bit mature, I should have waited a bit longer, but still good. So 6 implants are put in, 1-day surgery in the top, 6 in the bottom, and she comes at the healing stage. Everything is nice and healed up. A bit of overgrowth of the tissue and over one of those implants in the bottom jaw, but that's no big deal. That could be dealt with. That's the healing stage, and you can see how they slide into the bone, and they get bicortical stability in the bottom jaw, and the top jaw is almost all 6 of them are in the augmented bone. So this is one of them that is probably, I would have waited a bit longer just to have a bit more mature bone, but the bone is very soft. But that's prosthesis made PMMA with titanium bar inside, and trying to insert it. That implant was still moving, so I had to take that one out, but still 5 implants are holding it, and patient is very happy, and you don't need to go through another implant placement for her. So a very severe case and a significantly atrophic case can be dealt with a simple procedure. That's the final prostheses are placed in, and patient is pretty happy. So other cases that I started to use those implants for, here is for bridge works, for partial edentulous cases. 3 of those mini implants are inserted right away, and 4-unit bridge is placed on. So fixed restoration, nice and good outcome. Just want to show you how, when we see mini implants or miniature implants or ultra narrow diameter implant, what it really mean. In the few slides that I show you, they show how they slide into the bone and how they are placed without any guided procedures and any precision taken. So because they are torqued in and they are self-advancing, they tend to follow the softer bone, which is cancellous bone. So they kind of slide in between the 2 cortical bones. So when you face a cortical bone, you feel a bit of resistance, and they tend to avoid of it and slide into the softer bone. And there's a case that is done without any guided planning, any guided surgery. 5 implants placed in because of the limited spot that we had. And you can see from the picture here, from the CBCT, how well is embedded in the bone. In that case, if you try to use a conventional implant, you probably use good part of that bone, unless you do a split ridge technique or grafted or whatever, there's no way that you can drill that bone and be safe. And even if you have bone, who prefers to feed you suction with that bone instead of keeping and preserving that bone? So the big advantage of that is just preservation of whatever bone we have is being well preserved here. Another case, it just shows you how narrow the bone is and how it's been slided into the bone and stays in there. And the interesting part is because as soon as you feel resistant, you can stop, basically. They get bicortical retention pretty well. Even in that case, you can see it stops in the sinus. The sinus wall, as soon as you feel resistance and it's packed into it, it will stop. So you don't have to really push it more and end up with perforation and all sorts of problems. So this another aspect of it is how stable the bone level is, just to not having micro leakage between the pads and not having any micro pumping. This is after insertion X-ray that I took for that patient, 6 implants placed in each jaw, and X-rays are taken, and this is 2 years follow-up of the same patient. No drop into the marginal bone. Marginal bone stays absolutely the same level as it was at the insertion time. You probably can't see that with any conventional implant, really. It's well accepted across the board that you face 1 to 2 millimeter bone loss at the marginal bone level with any implant, and that's many factors are contributing into it, but probably the flap raising and micro pumping between the components and drilling into the bone are one of the factors in causing that result. But here you eliminate all of those. You don't have drilling, you don't need to raise massive flap, and you don't have micro popping, you don't have micro leakage between components. What would be the likely complications if you use those implants? Like we know, there's no safe procedure in dentistry. Anything you do, you gotta be prepared for part of it, for the side effect and part of the problems. So the general surgical complication that we always have, mainly depending on the host, the patient, and bone. So bone quality and quantity, probably not so much the quantity, is more the quality of the bone. That will play a big role here too. And also smokers and all sort of complications, that will be the same. There's nothing different in terms of how that affect this type of implants. Fracture during insertion, I believe that fracture during insertion is well eliminated in that design. The reason is that those implants start from 2 millimeter and above. So the smallest diameter that you have with these implants are 2 millimeter and then 2.5 and 2.8 millimeter. So from the previous study that I showed you, if you're not over torquing and you're not reaching over 40 Newton per square meter, then you're safe. There's no reason why you fracture it. So far, using almost about 200 of those implants, we had absolutely 0 fractures at the insertion time. And failure during the integration, that comes back to the first, actually. That would be the bone quality, that would be the previous infection in the side, with the host, whether smoker patients, whether it has medical complications, they all play a role. So you can't really have 100% success, it's just not possible. But eliminating many of those factors, you have better chance of osteointegration with this type of implant. Fracture during function, yes, they can happen. So you have severe bruxism, severe clenching, they still can be a risk. Probably less, that's pretty much reduced in this system if they are fused together, but still if tension is there and you have tension in the prosthesis and your prosthesis is not sitting passively on those implants, you still have a risk of fractures during function with this type of implants. So if I go back to the pre-implantitis we already discussed. The concern that I have is screw fracturing. The fixation screw still can fracture. So if you have a short bridge, like a 2-unit bridge, and those implants, if your implant doesn't fracture with severe bruxism, you still have a chance of screw fracturing inside the implant. They can be retried and they can be removed, but you have cases where your fixation screw gets stuck in there, is jammed, and there's no way around it that you can take it out. You may have to take the implant out. So, but that's what it hasn't happened so far after using so many implants. It hasn't happened to us, but that's one of the concerns that you need to look into it. And what I do usually when I have short bridges, like 2-unit bridge or 3-unit bridge, I try to have my restoration sitting on one implant, at least engaging the hex. So the other ones can be without the hex, using the hex, but at least one of them is using the hex. So in that way, you kind of remove that tension from the screw, pass it to the implant, and you have less chance of fracturing the fixation screw during function. Pre-implantitis and pre-mucositis is still a risk here. What I do to get around those implants is they come up with a millimeter of sandblasted or acid-etched surface, and they have 2.5 millimeter machined surface. So what I do, I usually go another millimeter deeper into the bone on the machine surface, trying to engage 1 millimeter or 1.5 millimeter of that machine surface into the bone. So even if you have a risk of pre-implantitis or any situation, you're still in a safe zone. So you can just clean it up or polish it, and that will deal with your pre-implantitis. Out of almost 200 implants that have been used over those years, we had 2 pre-mucositises. That's it. No pre-implantitis happened, and because of thanks to the design, what happens in those mucositises, I just flushed it and used a sand to polish around it, and that's it. That's the treatment done, and we didn't end up with any further complications. So no pre-implantitis has been reported so far. But still, like I said, the failure can happen due to overloading and bruxism or severe clenching. It can happen in your prosthesis, it can happen in your fixation screw, it can happen in your implant, it can fracture your implant. So, in terms of survival and success rate, we are in preparation for having a publication about that. Out of, like I said, 35 patients, and most of them are full arch patients, using almost about 200 of those implants. We had 6 failures at the healing stage, and most of them were kind of expected or can be well explained. The first one that I showed you was one of them, that the implant was placed in purely augmented bone and not mature enough. So it wasn't really a surprise to me that one failed. A couple of them failed because of impingement into the mental nerve, the anterior branch of the mental nerve. It was a bit wide and more than 2 millimeter, and that resulted in the implant failure. So we took that out, put a new one in. And a couple of them was because they were placed in previously infected sites. So probably having biofilm in that place was contributing to the fact that they failed. So nothing out of ordinary happened so far, and they've been behaving really well. Okay? So the success rate so far, before the publication, I can tell you, is about somewhere about 97% success rate in the healing stage in long term. Probably about 95% if you consider the mucositis and fracture that happened to those. And that's all. I hope you enjoyed it. And it's a pretty new system. It's coming along, and you are the first ones that heard about this one. It's already available. It's got a CE approval. It's got a TGA, and we're in process of getting the FDA approval for it. And we are, like I said, welcoming anybody that is interested in studying those implants. So any MOI students that looking for a master thesis and a topic for it, we're more than happy to support and provide help in those, and hopefully it will be a change and bring something new to the market. So add something to the library, implant library, and when you're stuck, at least you have another way of solving the problem and solutions.
So thank you very much.
Thank you.